of puberty, isn't it? The secondary sexual development. The breast, there are 5 stages. Breast and pubic hair. Right, the breast is more toward estrogen, and the pubic hair more towards androgen. Androgen. All right. Okay, so to grow the pubic hair, they need a androgen, whereas the breast is need estrogen. So this is the most mature, stage 5. Stage 5. All right, so this is the most mature. All right, so stage 4 and 5, not bad actually. But this is the most mature that we need to achieve. Okay, so this is the what happened actually, hypothalamic pituitary, like we clump together because it's about the same, hypothalamic pituitary, and then gonadotropin release the FSH LH, stimulate the ovary, and then ovary release the gonadal hormone, estradiol and progesterone. And this under this gonadal hormone, there are 2 effects. One is development of maturation of secondary sexual development. The other one is to start the menstruation. There are 2 things. Okay. All right. So there are 2 main effects. One is sexual development. The other is menstruation. That is at the puberty that's happened. So again, this puberty, there are 2 sides. One is physiological, the other one is physical, I would say. Physiological is mainly menarche, start the menstruation. And physical is secondary sexual characteristic. Telaki, some people say pubaki, this for pubic hair. Some people quote as adrenarche, it's about the same actually. And the other main feature of puberty is growth spurt, sudden growth. All right. So these are 4 main key in the puberty: menarche, telaki, pubaki, and growth spurt. There are 4. There are 4 main. So when you assess the patient whether this patient have reached a puberty or not, you look at these 4 aspects. Okay, clear? All right, let's go very slowly. Menstrual regularity, isn't it? Menstrual regularity. Okay, the normal menses usually 21 to 35 days, isn't it? The normal menses usually 4 weeks, isn't it? That's a normal menses, sorry. On average, usually 4 weeks, kan? Which is 28 days that we always quote, kan? Am I right? Yeah. So the range actually is easier to remember, is 4 plus minus 1 week, kan? Easier to remember. All right, there is what we call that normal menses. The range. So the average is 4 weeks, 28 days. The normal is 4 plus minus 1 week. All right, because 21 days is 3 weeks, 35 days is 5 weeks, isn't it? And so it plus, so the formula is 4 plus minus 1 week. And all right, so the cycle can be as early as 23 weeks. So 3-week cycles still normal, all right, and 5-week cycles, up to 5-week cycles. Okay. All right, so infrequent menstruation, the old terminology, we call it a oligomenorrhea, but the current terminology we call it infrequent menstruation. Infrequent menstruation is more than 35 days. Some define as 4 to 9 cycle per year. There is, I think, 4 to 9 cycle a year. All right. Whereas the amenorrhea is 6 months. 6 months. Amenorrhea is 6 months. We cannot point of 6 months. So there are 3 categories: normal, infrequent, and amenorrhea. Okay, clear? All right. So we go to amenorrhea then. So amenorrhea just now is no menses of 6 months, isn't it? No menses of 6 months is amenorrhea. So amenorrhea, let's say patient have menstrual cycle every 3 months, still not amenorrhea. Patient has menstrual cycle of 4 months, still not amenorrhea. All right. So when they come to reach 6 months, and then we call it amenorrhea. Okay. All right. So the amenorrhea definition is absence of menstruation of at least 6 months. At least, of more or at least 6 months. When they reach 6 months, is considered as amenorrhea. Okay. So how to classify? Classification of amenorrhea. There are two. We can classify into primary amenorrhea. The other one is secondary amenorrhea. All right. Of these two, actually secondary amenorrhea is more common. The incidence is 3 to 4%, whereas the primary amenorrhea is 0.1 to 0.3%. It's very minimum. Very minimum. So the definition, actually there are many definitions actually. So I use the definition in 10 teachers. Some people quote 14 years old with secondary sexual, without secondary sexual characteristic. The other one is 16 years old with well-developed secondary characteristic. I think it's very confusing, isn't it? I think make it very simple. I think the most acceptable classification of primary amenorrhea is 16 years old. Failure of girls to menstruate by 16 years old. By 16 years old. Whereas the secondary sexual characteristic, secondary amenorrhea is absence of menstruation more than 6 months, at least 6 months. All right. In normal female of reproductive age. All right. Okay. Some people stop shop here. Some people just stop shop here. Just stop here. All right. Just stop here. I mean, absence of menstruation in normal reproductive age. That's it. Stop shop here. All right. Okay. Or patient have menses previously, and then no menses for 6 months. All right. So they stop shop here. Okay. But some would go beyond that to say that it's not due to pregnancy, lactation, and menopause. I think some would just stop short here. So if you worry, you just keep to this one: absent of menstruation more than 6 months in patient who previously have menses. Okay, full stop there. All right, because this pregnancy, lactation, and menopause are natural causes of amenorrhea. Actually, we go to that later. All right, so I think I would suggest that stop here. Even though 10 teachers, they are extended up to pregnancy, lactation, and menopause. I think I'm worried that it come out in your MCQ, and then you'll be confused, isn't it? Isn't it? So right. So pregnancy, lactation, and menopause is one of the causes actually of secondary amenorrhea. That's one of the things that you need to roll out. Okay. So these natural causes: amenorrhea, pregnancy, lactation, and menopause. These natural causes. So causes amenorrhea, if you go down the ladder, there are hypothalamic, there are pituitary causes, there are ovarian causes, and there are, sometimes I would put that uterine and outflow causes together. There are four level, hypothalamus, pituitary, and ovary. This is usually the hormonal interaction, isn't it? Hormonal interaction. Whereas the menses come from the uterus, it doesn't come from the ovary, isn't it? So uterus and flow of the menses is uterus and outflow. Uterus and outflow. So there are two compartments. One is the compartment of hormonal, the other one is compartment of menstruation, which is uterus and outflow. Okay, clear? I think we need to stop once a while. I think 3 hours are very long. Okay. All right. So hypothalamic causes: hypogonadotrophic, hypogonadism. All right. All right. There are many actually. This is one of the causes. The hypothalamic causes, we call it hypogonadotrophic and hypogonadism. What does it mean? Mean that FSLH is low and low estrogen as well. Estrogen is low. It can be this. I divide this. This is primary. This is secondary amenorrhea. So excessive weight gain, excessive exercise, weight gain, weight loss, and stress can affect both primary and secondary amenorrhea. It can cause both. All right. Some craniopharyngioma, glioma, some of the lesion, hypothalamic lesion, compressing on the hypothalamic tissue, block the dopamine. Anything can block dopamine at the hypothalamic can cause amenorrhea. It can cause both primary and secondary. Any head injury, both primary and secondary. Okay, what about hypogonadotropic hypogonadism? Hypogonadism. Oh, continue of that. All right, there's a Kalman syndrome, we call it. Kalman syndrome is primary amenorrhea, does not cause secondary amenorrhea. This is X-linked recessive, resulting in low GnRH. All right, this is primary amenorrhea. All right, systemic disorder, sarcoidosis, tuberculosis, all these involve two, primary and secondary, but more towards secondary. Secondary. Drugs, progestogen, HRT, dopamine is more towards primary amenorrhea because very rarely we institute to kids this type of drugs. Okay. Pituitary cause. Pituitary cause. So pituitary cause, hypogonadotrophic, hypogonadism. Yeah. Hypogonadotrophic, hypogonadism. There's a primary and secondary amenorrhea. All right. Primary amenorrhea, the pituitary cause is congenital failure of pituitary development. It's very rare actually. It's more toward primary. Secondary pituitary adenoma. common in secondary amenorrhea. We talk about pituitary necrosis, Sheehan syndrome. This is very rare. What is Sheehan syndrome? Sheehan syndrome is patient have a massive PPH and then low BP, low blood pressure, causing death of the pituitary gland, death tissue of pituitary gland, pituitary necrosis. All right. Sometimes because of iatrogenic damage, whether patient have gone surgery or patient need radiotherapy that involve the brain, it can cause secondary amenorrhea. It can cause primary as well, but very rare, very, very rare. Okay, so far so good. All right.
Prof.
Okay, and then we go to ovarian cause. Ovarian cause. Primary amenorrhea, ovarian cause, we have sometimes ovary absent. There's absent of ovary. Absent of ovary. Like in Turner syndrome, 45XO. All right. Or 46XX. And we call it gonadal dysgenesis. Okay. They can have D45XO is chromosomal anomalies. Correct or not? The normal lady are 46XX kan? So there are two, it can be normal 46XX, but they have no ovary. We call it gonadal dysgenesis. All right. If they have one X, 45XO, we call it Turner syndrome. Turner syndrome. We will go to this. Just slowly. All right. For secondary amenorrhea, ovarian cause is anovulation. The commonest that we see in the clinical setting is PCOS, polycystic ovarian syndrome. Polycystic ovarian is secondary amenorrhea. It's not primary. All right. The next one is ovarian failure. We have ovary, but it's fail to function. Ovarian failure. Premature ovarian failure is defined as menses stop or ovarian function stop before age of 40. Before age of 40. Before age 40. Less than 40 years old. Alright, so what happen if ovarian failure? The ovary fail to produce estrogen, so become hypogonadism, and then pituitary still functioning well, so try to stimulate ovary, so causing high FSH LH. So we call it hypergonadotrophic. So hypergonadotrophic, hypogonadism. All right. So high FSH, LH, and low estrogen. Isn't it? Low estrogen. Okay, hypergonadism, high FSH, LH. Hypogonadism, I mean that low estrogen because ovary already failed. All right, the causes of ovarian failure, premature ovarian failure is autoimmune, sometimes metabolic disorder. In childhood, sometimes because of chemotherapy, patient have cancer, so she had a chemotherapy. So chemotherapy can cause ovarian failure. The radiotherapy also can cause ovarian failure. And they destroy the ovary. Not all actually, and depend where you target organ. Radiotherapy can target on on the lung only, on the brain only. So where the target is it? But it's target on the pelvis, more likely to cause ovarian failure because ovary in the pelvis. Okay. All right. So far so good. Okay. Outflow. Outflow is uterus, cervix, and vagina. That's outflow. Outflow. Because just now we discussed about from the pituitary down to ovary. This is just a hormonal mechanism, isn't it? but that what transpire actually is from the uterus, cervix, and vagina. Huh? All right. If let's say the we call that the hormonal axis complete or functioning well, but we don't they don't have uterus, problem uterus or cervix or vagina, the menses will not be happening, isn't it? Okay. For example, the primary amenorrhea, there is a normal uterine development, outflow tract abnormality, like imperforate hymen. Their uterus normal, everything normal, cervix normal, but the hymen is not perforated. The close, fully closed. So patient have no menses. No menses actually. The blood had been collected in the vagina, in the uterus, in the cervix. Very big, very big. I think I should have a photo for you. This imperforated hymen. So one of the causes is primary amenorrhea. The other one is when we have a problem with uterus, cervix, and vagina. Sometimes there is no uterus or undeveloped uterus. Okay. Just now we said 46XO kan. 46XO, not only the ovary that disappear, also the uterus is disappear. Uterus also disappear. Alright. But 46XX, there can be 46XX. 46XX, they are lady, karyotypically, but they have no uterus, no cervix, no vagina. We call it MRKH. This I will talk about it after this. MRKH syndrome. They have ovary, but they don't have uterus, cervix, and vagina. Faham? Alright. Okay. This we call it MRKH syndrome. Alright. So the other one is they are karyotypically is a man 46XY. They have Y here 46XY. But they are externally lady, but they don't have uterus, cervix, and vagina. And they don't have that. Alright. Okay, there are different names. There are many names for that. They are Gardner dysgenesis. They are complete androgenic insensitive syndrome lah. There are 5 alpha reductase. This is just a causes, but the karyotyping remain 46SY. Karyotyping, the phenotyping is the same. All this actually, they looks like lady. They're tall. They we call that. They have normal external genitalia, but they don't have cervix. They don't have uterus. They have some of them have testes. Some of them doesn't have testes. Confusing, huh? Alright, never mind. You type and then I will go to it after this. Whereas in secondary amenorrhea, as regard to the outflow, sometimes there is destruction of endometrium. Whether you destroy intentionally or not intentionally. Sometimes there's a scarring of endometrium causing Asherman syndrome. All right. Sometimes there is a treatment for dysfunction uterine bleeding where we do endometrial ablation. We ablate the endometrium so that we produce this amenorrhea. Amenorrhea. So if we this one. Okay. All right. Okay, so we stop shop there. What any questions so far? Any questions so far? Or we have a break for 5 minutes, huh?
Welcome, Prof. My name is Muhammad Jazli. I'd like to ask, would cases would abnormalities such as biconjugate uterus can also cause amenorrhea?
Jazli dia. Prof tak dengar.
Sabar je.
Kita break 5 minit, okay?
Nanti tajuk balik.
Type. Also
Huh?
type.
Kelas. Kena
Baik.
kiki dengan Prof.
Just explain. Type.
Yes, what was the question just now?
Sekejap. Welcome, Prof. So to little bit, I would like to ask, does such anomaly such as biconjugate uterus, can it cause amenorrhea? Like this cause of amenorrhea. Sorry, Prof. Your mic is not turned on.
They have mentioned there are two things very important. Number one is
The regularity.
number one is functioning hypothalamus pituitary ovarian axis, isn't it? Kan? Betul. Kan? There should be functioning, kan? It should be functioning. Number two,
The flow of the should not be.
the flow, the outflow, kan? The outflow. If outflow is pattern, outflow is normal, and then you have menses. Any problem with these two, the patient will not have menses, kan? Isn't it? If the patient have, understand, no?
Yes.
Yeah, if the patient have, let's say, problem with pituitary, but she have uterus, normal uterus, it does not have menses. Because these two has to function together. Okay, is it easy?
Okay.
Just try to make things easier. Kan? There are two main things. Number one is hypopituitary ovarian axis present and functioning. Number two is the outflow tract is normal, isn't it? And functioning. That's it. Only two. Okay, so if let's say biconic uterus, is it hypopituitary ovarian axis functioning?
No.
It's functioning, isn't it?
Functioning well.
Yeah, it's functioning. Kan? Biconic uterus, is it? Uterus is uterus is normal, abnormal lah, but it still have normal endometrium. Does it any obstruction to have menses coming out from the uterus? No, kan? So should not be a causes of amenorrhea, kan? Just concept reasoning, isn't it? Rather than memorizing, kan? So I just want you to understand the concept, the reasoning behind it. Okay,
Thank you, Prof.
yeah. So clear, everybody clear. So
Prof,
there are two things.
Prof, I have question.
Yeah.
May I ask? In the ovarian causes of amenorrhea, under the ovarian failure, there's the hyperthyroidism is considered also one of the causes under the metabolic or autoimmune disorder.
Sorry.
Under the ovarian causes of amenorrhea,
Mhm.
does it also explain the hyperthyroidism
Okay.
causing amenorrhea?
Some people say thyroid can cause amenorrhea. Isn't it? Amenorrhea. Amenorrhea. Not many cases actually. Very rarely, thyroid can cause amenorrhea. Um, it can. I didn't say it cannot. Isn't it? It can, but very, very rarely. Very rarely. Whether is it hypothyroid or hyperthyroid is, I think some people say hypothyroid, some people say hyperthyroid, isn't it? Thyroid dysfunction, I think can distract. Uh, I can distract. Okay.
Prof, and so is it if it is possible, in what mechanism that it affect the menstrual cycle?
Yeah, thyroid. I'm not sure actually where is distract actually. Where does it distract? I think I have to go and have a look again. But so far, nobody has explained in detail. Prolactinoma are different. Prolactinoma because of the production of prolactin, isn't it? That is disrupt the ovulation. I think hyperthyroid and hyperthyroid maybe most likely they disrupt the ovulation rather than other things. You know, they disrupt the ovulation. Probably they suppress the ovulation one way or another. So it makes the cycles longer. Can make the cycles longer. I think that is the most likely causes because during the primary infertility, we check the thyroid if the patient have irregular menses or infrequent menstruation, uh, as to ascertain whether thyroid dysfunction is present or not. I think the mechanism must be at suppressing the ovulation rather than other things.
Okay, thank you, Prof.
Okay.
Prof, in the presentation just now, head injury also can affect the can cause the amenorrhea. So
Yeah.
actually, how does it affect the hypothalamic pituitary axis
I think
actually?
must be something to causing the injury to pituitary or hypothalamus. I think.
Okay, Prof.
Yeah, I think must be disrupting the hypothalamus pituitary ovarian axis one way or another. But I think if the effect heat injury to other part of the brain, I think should not be an issue.
Thank you, Prof.
Okay. Okay, we stop for 5. Okay, Assalamualaikum. Is everybody here?
Waalaikumsalam warahmatullah.
Okay, so shall we start again? All right.
Yes, Prof.
So we go to epidemiology. All right. So the epidemiology, I went through few papers about this primary amenorrhea. Primary amenorrhea. Can you see or not?
Yes, Prof.
Okay, so the primary amenorrhea. Oh, sorry. The commonest actually is a MRKH. MRKH is Mayer, Rokitansky, Caster, and Hauser syndrome. All right. Bawa itu rocker mah. Pause 5 minutes. Okay. All right. So where we start just now, epidemiology, yeah. Okay, so the MRKH. The next one, the 46XX, gonadodysgenesis. What is 46XX mean that? What I mean by 46XX mean that normal female karyotyping. Am I correct? Normal female karyotypings. Gonadal just dysgenesis mean that the gonad is ovary, so the ovary has not developed. So 46SS, but the ovary is not developed. All right. Okay. All right. This the other study. The also the same. MRKH is common, very common. All right, very common. But having said that, in literature, in okay, in what we call that, in what to say, in 10 teachers, they said the commonest is not MRKH, primary amenorrhea. The commonest is Turner syndrome. Turner syndrome. In Turner syndrome, this 46XO, Turner syndrome. Turner syndrome. So not 46, not MRKH. All right. But a lot of studies say that MRKH actually is one of the commonest. I would say two commonest causes of primary amenorrhea is MRKH and Turner syndrome. Okay, clear? All right. So approach primary amenorrhea, the approach of primary amenorrhea. How to approach, isn't it? So if you have a cases of primary amenorrhea, how to approach them? Of course, as we always been taught, we start with history, examination, and investigation. We have to follow the flow. All right. So from history, you have to confirm whether is it primary or secondary amenorrhea. Secondary amenorrhea is patient have had menses previously. Whereas primary, patient has no menses previously. All right. So that from the history. All right. So examination. The few things that you have to examine. Number one, you have to examine whether any absence of growth spurt or not. Growth spurt examination. I call that evidence. Any growth spurt evidence or not. We're going to examine whether any characteristic of puberty in this patient. If she's having primary amenorrhea. So usually we take 150 centimeter. Anything below 150 we consider as short stature, and we can conclude that she has no growth spurt. All right. Second is secondary sexual characteristics. Minimum they should reach, 4. 4. If they don't reach 4, and then we call it then not developed. It's not developed. The sexual characteristic tilaki and just now puberty, isn't it? Tilaki and puberty. And we check the external genitalia, whether it's present or not. And we check the visual field examination. This is for pituitary tumor. Any visual field issue or not? All right, bilateral what? I can't remember already. The blackout of the lateral field, to show that there is a pituitary cancer pressing on the optic chiasma. All right. Okay, so that's the thing that you have to perform. Investigation. All right, the hormonal. You check the gonadotrophin, FSH, LH, estradiol, and testosterone. Testosterone in case that she actually 46XY. In case she's a 46XY, and you need to check the testosterone. Testosterone, because one of the causes actually, because the androgen receptor is not sensitive to testosterone in utero, so the baby become female actually. Become female. The testosterone level is normal, but the receptor does not respond to it. The blood, don't forget about karyotyping. This is compulsory in all cases. Primary amenorrhea, this is a routine. Routine. All right, and imaging. Imaging nowadays, we do a pelvic ultrasound. The best nowadays is MRI. MRI, that is the best. In the cases that you suspect any outflow issue, or any presence of ovary or absence of ovary, and you need to do MRI. Previously, we do a laparoscopy. Previously, we do laparoscopy. We do a laparoscopy. Oh, those days we don't have MRI. So what we did, we did diagnostic laparoscopy. And we have to look at the uterus, we have to look at the tube, we have to look at the ovary. It's our own naked eye. But nowadays, I think the laparoscopy has fall out favor because it's invasive procedure. Okay. All right. What is Turner syndrome? This is one of the most common causes of what? Primary amenorrhea, isn't it? Primary amenorrhea. Okay. All right. Is 1 in 2,500 live birth. Is one of the commonest female chromosomal and very common, commonest female chromosomal anomalies. It can have mosaic. You know mosaic, Mosaic mean that if you take karyotypings, there is two type of karyotyping, XX and as well XO. I mean some tissue have XX, some tissue have XO. I mean absent of one or absent as another X chromosome. So in mosaic, usually the feature will be variables. There's certain feature present, certain feature is absent. The key feature of Turner syndrome is ovary. This ovary absent or sometimes they present, but it's only with one strip of tissue. One strip of tissue which is not functioning, but both is supposed to be not functioning. All right. So it's non-functioning ovary. And the outflow can be normal, outflow can be normal, but because she doesn't have estrogen, so it's not developed. It's not developed. Other typical issue is short stature. Short stature. Very important. If primary amenorrhea, patient is short stature, they are almost always is Turner syndrome. Almost always. There's a webbing of neck. There is wide carrying angle of elbow. There's some other medical condition associated with this we call that Turner syndrome. Aortic coarctation of aorta, bowel disease. There's a deafness because of sensory conduction deafness, renal anomalies, some endocrine issues. There are many medical conditions. Right. Why renal? Because renal actually very close to uterine. This one female genital tract development in utero. So what's the treatment? Treatment actually we focus on the growth because she's short, so we have to try to make her taller actually. All right, and we try to induce the puberty by giving a hormone. Giving the hormone, we induce the puberty. If she wants to get pregnant in future, probably we can talk about ovum donation. All right, and of course there should be a psychological support, as you say, because it is abnormal issues, So she need time to integrate to the society. So this is a Turner syndrome. Turner syndrome. Short stature. This is webbing of the neck, aortic coarctation, poor breast development because of low estrogen. There's elbow deformity. We call it wide carrying angle. The elbow is all right. White space nipple. I think that is rudimentary ovary, or streak of the ovary, and she have no menses. Okay. Clear? All right. This is F45XO. Okay. All right. Can I stop for a while? 5 minutes. I have thing to do. 5 minutes. I come back again. And then we continue with 45XX and 46XX. This is 46XX. Okay, Assalamualaikum. All right, the first one is a 46 XO kan. All right. Now we talk about 46 XX. It's all 46 XX. This is the same thing actually. So you read this is about the same actually. Don't confuse. They are the same thing, just different names. All right. What happened to this actually? What the main feature of this? Number one, they have ovary. They have ovary. Ovary is present. Very important. Ovary is present and ovary is functioning. Functioning. Present and functioning. So what happen if these two ovary present and functioning? So what happen? So secondary sexual characteristic is normal. Secondary sexual is normal. Okay, understand? Ovaries present, function, and normal sexual. Okay. All right. So why does she has no menses? The menses because of the Mullerian system is not developed well. Mullerian system. All right. So there are different degree of maldevelopment. Different degree. Different degrees. The severe one, they have absence of uterus, no uterus at all. Some they have small uterus. All right. But the Mullerian system, what Mullerian system in fetus cause? They are developed into uterus and upper part of vagina, kan betul? Upper part of vagina and the uterus come from the Mullerian system. The lower part of vagina and external genitalia come from outside, kan? Come from outside. It does not come from the Mullerian system. It comes from the urogenital sinus, we call it. Come from outside. In the fetal development. All right. So it's quite common. 1 in 5,000. 1 in 5,000 is very common, isn't it? And is normal 46XX. You want me to repeat again? You want me to repeat again? Okay. This problem is outflow issues. Outflow issues. The hypothalamic pituitary ovarian axis are normal, functioning normally. All right. So mean that ovary is present. Secondary sexual characteristic is normal because ovary is functioning. The sexual characteristic are normal. So what is the problem? Problem is the Mullerian system. The outflow. The Mullerian system or Mullerian duct give rise to uterus and upper vagina, isn't it? So this not well developed and causing amenorrhea. Causing amenorrhea. Okay. All right. So etiology. Why does it occur? I think in last 1 month we have 2 cases in UIA, Mullerian MRKH. MRKH syndrome. Etiology is unknown, we don't know. The factor, the possible factor, it can be environment, genetic, hormonal, or receptor factor. But this is only possible. We cannot actually point out what is the main issues. Okay, so on examination, what you find? You find this patient have vagina. They have vagina because it's a lower part of vagina. Lower 1/3 of vagina. Alright. So they are blind end because the above part, the mullin system is not developed. It's not developed. They are short. They are short. They are short. So on ultrasound, what we see? On ultrasound, we see there is ovary and the uterus is small or abnormal. Alright, I forgot to put here actually the diagnostic is the scientific tools is MRI. MRI. So in this case, you need to do MRI. Huh? The MRI. This very important. It's a diagnostic. It's a diagnostic is MRI. Previously was laparoscopy. Right. Okay, so how to treat this patient? She has no vagina, so we have to create a new vagina for her. We have to create a new vagina for her. All right. She doesn't have uterus. So we can, nowadays they talk about uterine transplant, like a heart transplant. I think the success story of uterine transplant nowadays, patient already get pregnant with the uterus, which is I call it is a success. So this patient, actually this type of patient have future next time to get pregnant and have a kid because they have normal ovary. So they can produce ovum for pregnancy, but they don't have uterus to place the pregnancy. All right. Before this, we used to have a surrogate mother, get the ovum from this patient and do IVF and then put the embryo to the surrogate mother. But the coming issue nowadays is uterine transplantation. So patient can have menses again and patient can have pregnancy. Maybe in future you have a uterine bank, where we keep the uterus, so that this type of patient we can transplant the uterus. All right. Menses, how to create menses depend on the issue, but I think because ovary is normal, they should have no issue at all. All right. Pregnancy by IVF, or this one if we don't have the best actually by IVF. Where we do IVF because we don't have. If we transplant the uterus, actually we don't transplant the tube, The fallopian tube. and the fallopian tube. We just transplant the uterus. We didn't transplant the fallopian tube. So far, we have no this one. The uterus have been transplanted for pregnancy. So the pregnancy still have to start with IVF. We do IVF. After that, we put in the uterus. We put in the uterus. Okay. All right. Okay. And the surrogate mother. Okay. Okay. All right, understand this? Any question on this? Bit complex, isn't it? Sound very complex. You want me to repeat again? Huh? All right, we repeat again. This is 46XX. 46XX. These are the names. They reflect the same thing actually. Very common. Two common thing in primary amenorrhea is MRKH and Turner syndromes. All right. They have normal karyotyping. All right. They have normal axis, hypothalamic, pituitary, ovarian axis are normal and functioning. So they have ovary present, function normally, and they have a normal secondary sexual development. So what's the problem with them? The problem with them is outflow issues. The Mullerian system, the outflow system is not well developed. Then the Mullerian duct give rise to uterus and upper part of vagina. This is absent or become very small. So that this cause amenorrhea. This cause amenorrhea. All right. Etiology is not well established. Examination, you check the vagina, you external genitalia, because on examination the secondary sexual characteristics are normal. Secondary sexual characteristics is normal. Normal. It's normal. Secondary sexual characteristics were normal. But the external genitalia was normal, but the vagina, there is a vagina pit. Some people say blind and vagina, blind and short vagina. All right. On ultrasound, we see the ovary, but they're almost uterus whether small or absent. It's not well developed. Diagnostic MRI, previously laparoscopy. Okay. Treatment is we have to create the new vagina for her because she will have a sexual life. She needs a sexual life, so we have to create the new vagina for her. Make it longer for sexual intercourse. And nowadays we can do a uterine transplant to get the menses or to have pregnancy. But that does not mean that the fallopian tube is there or functioning. All right. So I think this one is not correct because she has a menses. She has a good normal menses, isn't it? And good and a normal hypothalamic pituitary axis. All right, and pregnancy conception, I think it's not pregnancy. I think the best word is conception. Conception is by IVH. Or fertilization is by IVH. Or fertilization is by IVH. by and then if they don't have uterine transplantation and we need to get the surrogate mother. Okay, clear? Yeah, all right. It's very complex, isn't it? Very complex. That's why we start with puberty and then you understand slowly what is the issue. If I jump to this one, I think everybody will confuse. And all right. So this is what happened with MRKH. This is a normal uterus. Uterus normal, ovary kan. So what is MRKH? This ovary is present and part of vagina, only lower part of vagina present. The rest is absent or rudimentary or small. Present but not functioning. Okay, nampak ke? Probably it should not be red, isn't it? It should be disappear kan? So that easier for you. I think should keep black or so you can imagine. So absent of uterus, tubes, tube also absent, and part of the vagina, upper 2/3 of vagina. The lower 2/3 come from urogenital sinus, come from below, developed from with the external genitalia. Okay. Alright, now we go to 46XY kan. Tadi 46X XO, 46X X, now 46XY kan. Kalau typing dia 46XY kan. So by right actually if patient have Y chromosome, they will have testes. Once a person have Y chromosome, they will have testes. If there's no Y chromosome, they cannot have testes. So this patient have testes actually. Testes. But why they become female? Why they become female? They are chromosomally men, but they become female. They have female features. But karyotyping is male. I've seen few cases of this. Where they are male. So very hard to say to them that you are male actually. So they are very hard to accept. I think I have seen 3-4 cases already. All right, so there are different type of the 46XY. 46XY. And three types. Number one is somehow the testis is regressed during fetal development. They call it gonadal dysgenesis. 46XY, gonadal dysgenesis. Mean that they initially have testes, after that they regress. We call it gonadal 46XY, gonadal dysgenesis. The second type is the receptors issue. Receptors issue. They have testes, they have androgen, testosterone, but the receptor cannot interpret the presence of testosterone into the changes. All right, so they have testes, normal testes. All right. So because of this, the fetus become female. Because the failure of testosterone to act on the receptor, and then it's become female. All right. The other one is the third one is we call it abnormal enzyme 5-alpha reductase. 5-alpha reductive deficiency. There's no 5-alpha reductase. What is this 5-alpha reductase? Is convert testosterone to the to dihydroxy dihydrotestosterone. Huh? They have testes, normal testes. All right. So why this fetus become female? Because the testosterone actually need to change to dihydrotestosterone to change the fetus into male. This is an active form of testosterone to create the genitalia, external genitalia to become female. So this issue of external genitalia actually. So external genitalia unable to be convert to male. So there's no there is no penis, no scrotum. It's unable because it need this change to this to change the external genitalia into male, into females, into male. Sorry, faham ke? Complex, eh? Repeat again. Okay. When I have this topic also, I'm worried that you don't understand. Alright. Okay, we have this 46 XY. Huh? 46 XY. Alright. Okay, 46. So chromosome Y, by right, they should have testes. Testes. Okay, clear that one.
Yes.
Alright. Okay, clear. All right. So there are three types of these anomalies. And okay, number one is they have test. They call it gonadal dysgenesis. Gonad. Gonadal dysgenesis mean that the testes disappear or regress. Sorry, regress. The testes regress. And so when the testes regress in utero, they form, but after that they regress for whatever reason. So when they regress, what happens is there's no testosterone. Okay, so there's no testosterone, and the baby fetus becomes female external feature. Okay, clear? Huh?
Yes.
The other one, the second one is receptor issues. Receptor issues. So receptor cannot interact with testosterone. They are testosterone, but they cannot react. They cannot interact. So they cannot we call that interpret or make changes. Testosterone cannot change into male. So this patient actually they have a normal testis. Okay. Normal testis. They have normal testis. They have normal, because they have normal testis, they should have a normal testosterone, kan? Correct. Because it secrete, the testosterone is being secreted, but the receptor cannot react with the testosterone to make a change. All right, but no effect because of receptor defect. So the fetus become female. Okay. So the external genitalia is female. Okay. All right. Faham, huh? Okay, never mind. Number 3, I repeat again. Number 3, enzyme defect. And enzyme defect. And number 1 is testis regression. Number 2, receptor defect. Number 3 is enzyme defect. Kan, the enzyme is unable to change testosterone to dihydroxytestosterone. Dihydroxytestosterone important to change the external genitalia to male. This is dihydroxytestosterone. So the fetus becomes female. Faham ke? Faham ah?
Faham, Prof.
Right. Clearer?
Clear.
Yeah, clearer. Huh? So there are 3 types. This 46XY. This approach I take 46XY now. You read the book, they go differently. They go gonadal dysgenesis, they talk about this. They go like receptor issue, they talk, and then you confuse. So I just want to make things easy for you. So 46XY. All right. Okay, clear? Huh? Any question up to this stage? Can absorb. That's why I want to break this, because the first part mineral are very confusing, bukan confusing, very detailed, very fine detail. Now we almost 10 o'clock. We still stuck to this kan.
Ada question dalam chat.
Huh?
There is a question in the chat.
Okay, somebody asked the question in the chat. Sorry?
The question is, for the second time, does it mean that the person will have both female and male genitalia?
Genitalia actually they are lady. Their feature is female features. They are lady. That's why this patient come complaining of primary amenorrhea. The family thought they are ladies. They born like a baby girl, as a baby girl with external genitalia.
Oh, but they are male.
Faham ke? They are born with as a baby girl, so they come with primary amenorrhea. They said, my girl still cannot have menses yet. Actually, they are not girl. They are male. 46XY. Faham ke? Now you understand? Eh?
Yes.
It's like they are girl actually. They are female feature. This female feature. They are female feature. They are female feature. Okay. Sound very interesting, isn't it? Okay. All right. So the feature is they have a blind vagina. Blind vagina. See that? They're blind vagina. The vagina is blind because this is the development. Why I think probably next time I should put slide on development, fetal development. The development of vagina, external vagina, 1/3 of the lower vagina come from outside, come from the external genitalia. External genitalia. They develop with vulva, labia minora, labia majora, and lower part of vagina, they develop together. Okay, all right. See, the external genitalia are female, kan? As I said, they have labia minora, they have labia majora. They have breast, but their breast is not well developed because there's no estrogen. Estrogen need to be there to make it well developed. Secondary sexual characteristic is depend on the estrogen. All right. See, the female sexual characteristics not well developed. Okay. And they have a primary immuno. Of course they have primary because they are not lady, isn't it? They are not lady. They are not lady. They cannot have menses. And they are not lady actually. Karyotyping, they are not lady. Genetically, they are not lady. Okay, so an examination, what you see, I think I have to put here, underdeveloped. Sexual characteristic. They underdeveloped, kan? Because they are male, and one thing, they are tall actually. They are tall. They are a lot. They just like model, no? Very tall because testosterone effect on others, but not on that sexual development. And so they are tall. Sometimes they have different voice, different voice. So they are tall. They are tall. So this is 46XY. And the vagina is blind. As I said, we repeat again the same thing. And ultrasound, absence of small uterus, ovary, and I think we need an MRI, kan? To diagnose the outflow, kan? We need the MRI. We need the MRI. MRI. Okay, this case usually I will do the laparoscopy and look at the, usually we look, there is no uterus, no tube, no ovary, nothing inside. It's just zero inside. It's just zero inside. So they have nothing inside. They're just zero inside. So yeah, very difficult to say to the patient that you are not female. They've been brought for 16 years to become female, isn't it? And then suddenly they say, no, you are not female. I think it's very heartbroken. Very heartbroken. So the treatment is we need to remove the testes because the testes have a malignant change. The testes have malignant change if we left behind. So usually we remove the testes. We find the testes, we just remove it. And definitely the psychological support play a big role. I think very devastated for them, isn't it? And they need a long-term HRT so that they can, sexual characteristic, secondary sexual characteristic can develop, And we try to make a new vagina, or make it the vagina bigger or longer, sorry, so that they have a normal sexual characteristic. They are lady. They've been brought like a lady. I think we cannot change their life to men. It's very unfair. Very unfair. Very unfair. I met few. I think it's very difficult. It's a very difficult life for them. Okay, and then the pregnancy. It's not in the book actually. I just put it there. Can they get pregnant in future? We never know. Actually. We never know. We never know. We never know. I hope they can get pregnant in future and things, but we never know. Okay. With the uterus around, we never know all the technology future. But so far, we cannot get that pregnant yet at the moment. Okay. All right. This is the we call it last time they call it the name we call it last time is this type of problem we call it those days lah when I was a junior specialist we call it testicular feminization. This is an old term. We call it this patient testicular feminization. But this term not be used anymore. Orang tak guna dah sekarang. Just to tell you that they have a testis, but they're lady. We call it testicular feminization. But this terminology is outdated already. People don't use anymore. Okay. So they are female face. They have breast growth, but secondary sexual characteristic is not present. They have lean muscles. Sometimes they have a testis stuck at the inguinal ligament, inguinal canal. But the external genitalia are lady. Their lack of pubic hair because testosterone does not have effect on the female sexual characteristic. Okay, shall we stop for 5 minutes? I think very heavy, isn't it? I'm worried that you don't catch what I'm saying. Very worried because this slide I've been this lecture, take 2 days for me to sit down and write. Don't know how to, review and review again because worried that, by the end of the lecture, you still confused. So try to make it as simple as possible. And then need to start from beginning. If I start in midway, I think you just lost. Actually, what is we talking about? And you have to start with puberty. What is puberty? And then you understand. Probably, I think I should start with fetal development in utero, and then you understand much better. I think I should put that in the first slide, so that we discuss a bit. Okay. I don't think I can finish the whole thing today. Shall we rearrange next time again? Because 11 o'clock I have to see patient. I have appointment with patient. Probably the second part, the early pregnancy, we do one session again. Boleh? Boleh. Okay. Sorry Okay. So far so good. Any question? Okay, what is approach to secondary amenorrhea? Again, history. First, you have to confirm whether patient have secondary amenorrhea or not. Confirm the secondary amenorrhea. Kan? So secondary amenorrhea, you have to make sure that the patient is having menses previously. She has a menses. Now she doesn't have menses. That is means secondary amenorrhea. And it has to be 6 months. 6 months. 6 months. All right, from history, you try to rule out natural causes of secondary amenorrhea, whether it's pregnancy, menopause, or breastfeeding. This is, I call it common, very common, very common. So you need to ask about LMP, and then you need to ask about symptom of pregnancy. What is symptom of pregnancy? Nausea, vomiting, isn't it? Breast tenderness, and any sign of early we call that pregnancy. Similarly, menopause, you have to ask about symptom of menopause, isn't it? Hot flushes, insomnia, mood swing, and all these symptom of menopause. And the third is ask about patient have breastfeeding or not. Patient whether still have breastfeeding, probably the kids 1 year plus but still be breastfeeding. So that can cause secondary amenorrhea. All right, all these things need to rule out by history. By history. In the history, you should take good history. Sometimes stress. Example is exam stress. Kan, if you stress in the exam sometimes you have your menses going to be disturbed. And for example, so any stress, occupational stress, emotional stress. All right. Anorexia, one of the causes. All right. But I think in Malaysia, not much, not many, as far as stress and anorexia is concerned. All right. Okay, examination, you have to check the BP, hirsutism. BP, why BP? Because is related to PCOS. And PCOS has high incidence of, we call that blood pressure. Apa ni? Blood pressure, yes. Secondary amenorrhea, the common cause of secondary amenorrhea actually is two only. Common. We talk about common. Common is, of course, apart from this, pregnancy, menopause, breastfeeding. There are two common things is PCOS and premature ovarian failure. Those days they call it premature menopause. Dulu lah. Sekarang people don't call it premature menopause. But those days we call it premature menopause. PCOS and premature ovarian failure. Alright, so PCOS, they are high incidence of blood pressure, hypertension. You have to look at hirsutism, you have to look at BMI, obesity, you have to look at galacturia. Galacturia is associated with hyperprolactinemia. This is pituitary adenoma. Pituitary adenoma. Quite common, this hyperprolactinemia. Quite common, pituitary adenoma. They have two types of pituitary adenoma. One is macro, another one is microadenoma. Macroadenoma and microadenoma depend on the size of the tumor of the pituitary. And this patient have I put here, visual. This patient I have to put visual examination. Visual examination. We should have visual examination. The primary, you can as well, but this is it's a must. It's compulsory. Make sure that there is no pituitary adenoma. Pressing on the optic chiasma. Okay. Investigation, same. FSA LH, estradiol, testosterone, and prolactin. Because prolactinoma. Additional is prolactin. Prolactin. So if patient you suspect PCOS and you need to do a lipid profile and you do the MOGTT, to diagnose diabetes. Okay. Imaging, we can do a pelvic ultrasound. Sometimes the best is transvaginal scan. If the patient is not virgin and we do a transvaginal scan, we look at the ovary. Ovary. They call it necklace sign. Necklace sign. Alright, what is PCOS? PCOS, huh? So PCOS is I think the three main criteria of PCOS. Number one is menses. Number two is clinical feature. Be menses and this one the same. I think I have to put here the same. Clinical feature. Sorry, one. Number two is I'm going to say physical features. I think the best. And the same as clinical. Sorry. The other one is the hormonal. Sorry, hormonal. And the other one is an ultrasound. All right. So clinical features PCOS is amenorrhea or oligomenorrhea. And then hirsutism. And then obesity. I think these three main very important. Sometimes patient come with subfertility, infertility. Infertility. All right, this is clinical feature: amenorrhea, hirsutism, obesity, and infertility. All right, hormonal. They have reverse aphasis. Sorry, aphasis, LH ratio on day 2 menses. Day 2 menses. Okay. And they have high testosterone. Okay. And they have high testosterone. I think that's the main thing. 3. And they have low progesterone day 21. That is mean that patient have anovulation. Okay. Ultrasound. So ultrasound, the best is by TVS. So what we did is we look at the ovary. There is a small follicles.
Prof
Prof,
left.
Prof.
Prof still left.
Jadi kita tutup cerita dia.
In context menu.
korang untuk session kali ni dah habis. Prof akan postpone yang PCOS ni ke topik yang satu lagi yang early pregnancy tu. Bila
Okey
tu
ni.
bila tu Akid nanti cakap balik
Ini
Okay, kita tutup dengan tasbih haratan Sarawak Acap tu.
Thank you dekat Prof semua.
Thank you.
Thank you, Prof.
Thank you, bro.
Assalamualaikum.
Thank you, Prof. Ni.